Hi, this is Mrs. Hauk. This is the second PowerPoint about dysrhythmias. This is the first podcast of this PowerPoint. We've already discussed how to identify the P wave, the QRS complex, and the T wave, how to measure the PR interval, QRS complex, and QT interval, some basic steps in identifying and interpreting a rhythm strip. So let's talk about specific dysrhythmias now, their causes and treatments. Dysrhythmia is any disorder of the heartbeat or heart rhythm. When you have a dysrhythmia, your cardiac output is impaired. Therefore, your cellular oxygenation is also impaired. Dysrhythmias are typically classified to their site of origin, whether they originate at the SA node, somewhere in the atrial tissue, the AV node, the junctional tissue, or the ventricular tissue. What happens is they're caused by a disturbance in an impulse formation or by conduction delays or blocks. Remember, in the heart, every cardiac cell has the properties of excitability and automaticity. This is just a picture reminding you of what the electrical conduction in the heart looks like. You'll see the SA node, it goes out into the atria. This is the AV node and the junctional tissue, and then down into the ventricles, the right bundle branch and the left bundle branch. Some terminology: tachydysrhythmias mean you have a heart rate greater than 100. This means there's shortened diastolic time and coronary perfusion time. The heart's not resting and filling, and it's not having enough time to perfuse the coronaries like it would. This will increase your workload of your heart and increase oxygen demand of the heart. Bradydysrhythmias is when your heart rate is less than 60, and the rate's too slow to provide an adequate cardiac output. Premature complexes, this means a cell other than the SA node becomes irritable and fires an impulse before the SA node can fire the next complex. It can be atrial, junctional, and ventricular. If frequent enough, these will cause decreased cardiac output. And then finally, paroxysmal. This means the rhythm is intermittent and resolves without any intervention. Or another way to say that is self-limiting. Paroxysmal rhythms are initiated by premature beats, either a premature atrial contraction or a premature ventricular contraction, which we will call PAC or PVC. Symptoms commonly seen with dysrhythmias. Dysrhythmias cause an impairment of cardiac output and therefore perfusion. So any sign or symptom of decreased perfusion is a symptom of a dysrhythmia. This is probably going to be one of your most important slides because you're going to want to remember all these signs of decreased perfusion. Hypotension is the first thing we think of, and that's why it's bolded in red. We always think of hypotension when we think decreased cardiac output, decreased perfusion, but there are a number of other symptoms, and not everybody with dysrhythmias will have all of these symptoms or even have hypotension. They may just have weakness or fatigue. They may just be diaphoretic and have palpitations, dizziness, syncope, short of breath, chest pain, palpitations, pale, cool skin. Don't forget about your delayed capillary refill, and most importantly, your decreased urine output. Your kidneys are going to be the first organ system to suffer from decreased perfusion. So this is always a good sign. Are my kidneys being perfused? Sinus bradycardia. In the last PowerPoint and series of podcasts, we talked about sinus rhythm. Are characteristics of sinus bradycardia. Basically, it's just like sinus rhythm, except for it has a heart rate less than 60. So all the characteristics of normal sinus rhythm, except for the heart rate is less than 60. Causes: vagal stimulation. You bear down, you cough, you sneeze. This slows down your heart rate. Beta blockers, they're given to slow the heart rate. That is their purpose. So people who take beta blockers may run a slower heart rate. Anti-anxiety meds, they're meant to relax you, and part of relaxation is slowing your heart rate. Conditioned athletes, those who train or run, they're going to have lower heart rates, and that's going to be normal for them. So before you get excited about your patient with a heart rate of 45, look at these, remember these causes and think, is this normal for this patient? And sometimes you just have to ask them, is this a normal heart rate for you? You treat only if the patient is symptomatic. So if the patient's not symptomatic, we're not treating it. And what we treat sinus bradycardia with is a drug called atropine. It's an anticholinergic. Any medications discussed in these lectures are fair game for test questions, so I suggest that you study these medications. This is what it would look like on a strip. If we counted the number of complexes, it would equal a heart rate, approximate heart rate of 40. Sinus tachycardia. All the characteristics of normal sinus rhythm: a normal PR interval, QRS, QT, it's regular, a P wave for every QRS complex, except the heart rate's greater than 100. Causes: anxiety, fright, stress. It's part of our fight or flight mechanism. We get tachycardic. Normal response to exercise. If we're in pain or have a fever, we're going to get tachycardic. If we're hypovolemic or hypoxic, it's a compensatory mechanism. And alcohol ingestion. You can sit at a bar and drink all night and be tachycardic from not even moving, because alcohol is a natural stimulant for your heart and will increase your heart rate. And then all those medications that we think of when we think of things that stimulate you. Caffeine, number one. Catecholamines, which would be your epinephrine or norepinephrine, atropine, nicotine, thyroid medications, and dopamine. And when we start our patients on thyroid medications, we need to monitor their heart rate, because if they get tachycardic, that will tell us that they're on too much of a dose. We only treat if the patient's symptomatic. And most of the time, the treatment that we're going to do is treat the cause. Is it caused by anxiety? Let's calm down. Is it caused by pain? Let's give pain medicine. Is it caused by fever? Let's treat the fever, get the temperature down. This is what a strip of sinus tachycardia would look like. And if we count the complexes and get an approximate heart rate, we'd have a heart rate of 140. So that's sinus bradycardia and sinus tachycardia. Now we're going to move into the atrial dysrhythmias. 4 types that you need to know. There are a lot of different dysrhythmias. I'm keeping this very basic for you. You'll get more advanced EKG training if you work on a telemetry floor or an ICU, but we're sticking to some basic things to help you in the beginning get a good sense of what dysrhythmias are. We're going to talk about premature atrial complexes, or PACs, supraventricular tachycardia, or SVT, meaning it originates above the ventricles, atrial fibrillation, and atrial flutter. Causes of atrial dysrhythmias are things that stimulate you, sort of like the causes for sinus tachycardia: hypoxia, stress, anxiety, infection, fatigue, myocardial ischemia, and electrolyte imbalance. The stimulant drugs: alcohol, nicotine, caffeine. And anesthesia can cause atrial dysrhythmias. So in this slide, we see a normal rhythm in the first 2 beats, and then we see a third beat, which comes at the same interval, but the fourth beat, looking at this, comes early. This is what we call a premature atrial contraction. A premature atrial contraction looks just like a sinus rhythm beat, except for it comes early, because there's a cell in the atrial tissue that fires early. The atrial tissue, for whatever reason, is irritable and fires an electrical impulse early. These are non-life-threatening. However, they can become frequent enough and become a precursor to AFib or flutter. And basically, this is just a picture showing you the SA node fires and goes right to the AV node. Here, before the impulse from the SA node can reach the AV node, this cell fires and gets to the AV node first. Therefore, we have an early complex seen here. Treatment. If the patient is not having frequent ones and they're not symptomatic, there is no treatment. We just watch it to make sure they don't get more frequent. But if they are pretty frequent and we might be concerned, there's other reasons why we'd be concerned our patient would go into AFib. We'd give them oxygen, look at their electrolytes, replace their electrolytes, and if they're frequent enough, we're going to put them on medication. Medications of choice would be amiodarone, metoprolol, and digoxin. I'm going to back up a minute and talk about electrolyte replacement. So an electrolyte replacement, what is your normal potassium range? Think about that and think about what your normal magnesium range. Those are the 2 electrolytes that we're going to look at when we look at electrolyte replacement for dysrhythmias. Now, I can tell you that if your patient has some kind of cardiac issue or concern for dysrhythmias, they want to keep that potassium at 4 or above and the magnesium at 2.0 or above. Those may not be the low normals, but that's where we like to keep the electrolytes when we're considering these situations. Also, when you see a patient on metoprolol and you're asked by an instructor why they're on metoprolol, a big pet peeve of mine is they are not for just blood pressure. Figure out what kind of metoprolol your patient's on and what's in their history that says why they may be on the metoprolol. Metoprolol tartrate and metoprolol succinate are 2 different types of metoprolol. Metoprolol tartrate is a short-acting and is used in MIs and dysrhythmias to decrease workload of the heart by decreasing heart rate, suppressing dysrhythmias. Metoprolol succinate, on the other hand, is used in heart failure patients and is a long-acting metoprolol. And that may be used for blood pressure in congestive heart failure patients. So not all metoprolols are the same. Know why your patient is receiving their type of metoprolol. The other thing is digoxin. The only time digoxin is used as an antiarrhythmic is in heart failure patients. You are not going to see a normal 50-year-old patient that's relatively healthy, starting to have problems with dysrhythmias, get put on digoxin for the dysrhythmia. Digoxin is relatively used these days just for heart failure patients. This is where I'll stop this podcast, and we'll begin the next one talking about SVT or supraventricular tachycardia.